go. So I guess we're supposed to go. Good morning.
Good morning, Carolyn.
Carolyn Shapiro.
Carolyn Shapiro.
Yes, good morning. Good morning, Dr. Rosensweet. And the beast was sleeping and now he's wide awake. So please forgive in advance.
Who's the beast? Who's the beast?
You know who the beast is. The cat.
Oh, the cat is fine, Carolyn. I think the cat has a special interest in menopause and we want to respect that.
Oh, he talks to me about it all the time. It's just your voice that sends him flying over here. It's so weird.
All right, good.
Yeah. So we're going to start off with our questions. Welcome everybody who's going to be coming up. Happy, wonderful 4th of July in advance. You guys stop. Okay. So question number 1 comes in stating, I am having trouble with cystic acne. I don't have any hair loss. I don't have oily skin. And could this be from testosterone, do you think?
Yes.
Oh, okay, good.
Well, I mean, it's one of the ways that we monitor testosterone dosage. What is missing from this particular questionnaire is sufficient data that would help sort out whether that is part of the issue.
Got it.
You know, this is always done in any kind of intake interview by any kind of healthcare provider. There's a lot of clues to testosterone overdose, but yeah, if a woman is not used to having acne or cystic acne, and then she starts taking hormones and she gets acne, the usual provocateur is excessive testosterone, not testosterone, because there are some rare exceptions in the perimenopause when women are producing an increased level of testosterone. But there's such data missing from the questionnaire. But let's say that she was in the perimenopause.
Okay.
And the ovaries are shutting down estrogen production and testosterone production and DHA and progesterone production. And there is a brief way to compensate for a woman whose adrenals are doing pretty well.
Oh.
Or even the ovaries themselves can produce a little extra testosterone. So there's a few women who enter the perimenopause, and when the estrogen drops, their testosterone increases. And what her body can do is convert that testosterone in the fat cells of a woman's body into estradiol.
Wow.
So this is a protection mechanism, and you're going to see it every so often. There's going to be women entering the perimenopause who they've got a slightly elevated testosterone. And we're very cautious with those women. We don't immediately treat them with testosterone.
Right.
Now, having said that this exists, it's actually more uncommon than ever before these days. I used to have to watch out for it back in the day when I started off all this work. But I'm finding it less and less that women are entering the menopause or perimenopause with adequate testosterone. More often than not, I'd say, God, in my patient demographics, it's down to about 10% or 5% of the women that I'm encountering in perimenopause or early menopause are actually got an elevated testosterone. No. The vast majority of them, 90-95%, wild guess in my practice, are entering into the perimenopause or menopause with lower testosterone than they've ever had. And certainly not elevated, certainly less. Well, how in the heck does that happen? Well, as I've mentioned many times, the stress response, the biology of the stress response of fight or flight, that means saber-toothed tiger, or you didn't make your last mortgage payment, or you're having an altercation with people that you care about in your life. Stress, whatever any kind, the biology is always the same. Your body thinks you're being attacked by a saber-toothed tiger, even if you're just uncomfortable about friendship or communication issues. You're gonna do the saber-toothed tiger thing. And so you're mobilizing for fight or flight, and you're using your power, your superpower biochemicals to do that, called hormones. And at the vanguard of the biology of that stress response is adrenaline and cortisol. But they're not the only hormones that are called in, because estrogen's energizing,
Right.
testosterone is energizing, thyroid's energizing. So all of these hormones are recruited, especially in the day after day or month after month or year after year of triggering the biology of the stress response. And so what happens by the time a man enters midlife, or a woman enters midlife, we've done so much over recruiting of our sex hormones. My God, a lot of men can't even get an erection like they used to when they were young. 40s, 50s. Why'd that happen? They recruited their testosterone for the biology of the stress response and wore the testosterone production down, the ability to produce it. Same with women. Women have been recruiting their estrogen and their testosterone for the biology of the stress response because they work so well for that. So I'm going back to the questionnaire. 95% of the patients that I've encountered, especially in the last decade, these women are entering menopause not with elevated testosterone, no, with diminished testosterone. And the questionnaire that we send out for the first consultation, in which we're trying to understand what's going on in a woman very, very thoroughly, it just shows us in many ways that her testosterone is low. And now I consider it a rare exception that a young woman is doing that. A woman in the perimenopause is doing that, not low, but slightly elevated testosterone. So we don't routinely prescribe to every woman in the perimenopause or menopause, let's start off with testosterone too. No, we don't do that, because there are these where women, they are floating in a little higher level of testosterone that will not sustain. There is no single woman I've ever tested who's been 3 years into the menopause with normal testosterone and DHEA. No, never happens.
Right.
Hundreds and hundreds and hundreds and hundreds of women, never happens.
Right.
But why I'm mentioning this is because the questionnaire asks, can I get cystic acne? Well, can you get acne? And yeah, maybe you're one of those women. We don't know anything about you, but perhaps you're one of those women who enters the perimenopause or early menopause with a slightly elevated testosterone. And if you're getting treated with testosterone, you're going to push yourself into elevated testosterone levels. Ask any teenage boy and many teenage girls if they've got a problem with acne or cystic acne. Hey, I was one, got to go to the dermatologist. My mom used to take me for my acne. Well, thank God I had a robust testosterone output, not so much the acne part. So you can get acne, you can get pimples, you can get greasy skin. And just because you don't have greasy and oily skin, but you do have acne, well, anyone who is skilled, any healthcare provider who's skilled and experienced in treating women with hormones are going to know this, are going to be able to identify this. And if this is the cause, there'll be a dose adjustment or stopping for a while. You will run out eventually. You're going to need testosterone sooner or later. I think giving women testosterone is one of the most important things that we do in treating women in menopause for the long haul. It keeps you out of canes, walkers, wheelchairs, and assisted living, and it protects your bladder in very crucial ways. Not the only thing, so that you don't have to get adult diapers, and that can keep you in your home every day of your life that you're on earth, rather than make it so difficult for you or your loved ones that you need the extra care, bless their hearts, of assisted living facilities and nursing homes. But we could, nursing homes and could be partially emptied, and Medicare could be spared enormous expenses just by treating women with testosterone long term. So it's a big deal. It's a big subject. That's why I'm honored and grateful to field a question like acne.
Yeah. Yes. I do see it quite a bit, pretty much in young people.
Yeah.
I escaped that one, thank you, God. But I celebrated the one pimple I did get when I started hormones. I was like, something's working here. I was very happy, to have a pimple. Nevertheless, I don't think that acne can be any fun at all. So I appreciate that answer, and I'm sure that the questioner appreciates that answer. And I'll go ahead and move on to question number 2, which I think you probably will enjoy. Is breast tenderness an alert for high levels of estrogen in a menopausal woman? I'm using an HRT cream.
Yes.
Okay.
Oh, you're waiting for a few more words, I guess. Okay. Well,
Just a few.
young women who have breast tenderness or are not being treated with hormones, they're not having a perfect balance between the stimulatory effects of estrogen on the breast, which stimulate actual breast glandular cell proliferation. And breasts get fuller once a month in preparation for possible impregnation and lactation. Breastfeeding process begins every single menstrual cycle.
Yes.
And the balance between that and progesterone, which quiets down stimulation effects of estrogen. So if a young woman gets out of balance and she doesn't have quite enough progesterone to balance her estrogen, she can get breast tenderness. Now, I've heard gynecologists say that a little bit of breast tenderness, a little bit of PMS in a young woman, they think it's fabulous because
Uh-oh.
even the comment around acne, actually. I've heard gynecologists say, a little bit of acne, a little bit of PMS, a little bit of breast tenderness, you're dealing with healthy, robust hormones there. And that's a good thing in a young woman. Just like when I had some pimples and acne when I was an adolescent. Now, let's back it into treatment of women in menopause. If a woman going into menopause and she does not have breast tenderness and she's getting treated with estrogen, as every single woman on the planet Earth should be, no exceptions. And every single woman on the planet Earth should also be treated with progesterone and testosterone and DHEA, not to mention thyroid in many cases. No exceptions. That's every single woman. We're talking billions here.
No exceptions.
No exceptions in the menopause. If a woman's went into perimenopause or menopause and didn't have breast tenderness and started getting treated with hormones and developed breast tenderness, there's one of two things that are going on. Either she's dealing with an excessive dose of estrogen, or she's not getting a sufficient amount of progesterone to balance the stimulatory effects of the estrogen. One or two or both of those things are happening. So if you're dealing with a provider that really understands and has training experience in treating women in menopause, they're going to know that instantly. And, you can also pick up that in our book, Happy Healthy Hormones, which you can download from Carolyn's site. And yeah, that's where the action is. Now, when a woman starts taking estrogen and progesterone in menopause, sometimes there is a little bit of initial breast tenderness. The technical explanation, I believe, has to do with receptor sites and receptor sites having gone dormant and flooding the receptor sites. And you don't need to know these details, and they don't matter. What we'll say in the menopause method is if you get a little bit of breast tenderness, just keep going. See what happens. Very often that little bit of breast tenderness will go away, even though you're increasing your dosages of bias and progesterone. It'll go away. Now, moderate breast tenderness or breast pain or nipple pain, no, we take a different course when that happens. We'll slow down the dosage determination process. We might have a woman stop for a day or two. And that's all guided by someone who's trained and experienced on how to guide women in this.
Right.
So, yeah, a lot of breast tenderness will go away, and we'll just and even in the face of increasing estrogen doses, but some won't, and we've got to stop and back down the dosages. But under the guidance, and this is your job, once again, your main job is go shopping, find a healthcare provider that's really interested in menopause and is specializing in it, has special training and maybe even mentoring. And they'll help you figure it out. Or join the menopause method. You're dealing with experts that are being mentored. They're in basically a residency program.
Absolutely.
You're dealing with us. So yeah, those are some details about some breast tenderness. Long term, we call our method one of the, what do they call it? Subtitles of the menopause method, or caveats or mantras of the menopause method, or whatever you want to call it.
Like that.
Pardon?
Mantras. I like that.
Yeah.
Mantras of the menopause method.
We are a no breast tenderness method.
Right.
That means that sooner or later, we're going to correct that. And it's 99% of the time correctable. Because if there's breast tenderness, there's an imbalance, there's overstimulation of breast glandular tissue, that can increase breast density. And that is, breast density is not healthy for a breast. And breast health is at the bottom line of any treating woman in menopause with hormones. And it's a solvable issue if you've got breast tenderness. It's a solvable issue if you have increased breast density. So again, in the hands of someone who really has been trained and experienced in this and are mentored in this, these are always dealt with.
Got it. Got it. Yeah, I'm going to save my own thought question about that for later.
All right.
Yeah, because that'll take us deep into the tundra, as you say. I then will move on. So, yeah. Questioner says, Dr. Rosensweet, I still do not understand how it is that estriol helps at all.
Yeah, I love this question. It's one of the foundational issues of how imperative it is that we protect access, because your access is threatened, women and men. How important it is that we protect access, one of many reasons, to compounded bioidentical hormones. Well, let's just start with nature. And I'm just blown away sometimes by some of the theories I see put into practice in medicine, where it looks like they're trying to invent a different woman. And I'd like to put in my vote for the original design of women and men. It's just so astounding. We can't even begin to get our brains around how fantastic it is. I don't even have words to describe, what's going on in the human body. And I remember in medical school on several occasions, I'd come to tears reading something about in biochemistry or physiology. Like, it's just incomprehensible, the intricacy and the orchestration. I mean, you want to believe in the divine, go to medical school. I recommend.
Absolutely.
Having trouble deciding whether God is all that is real, just go to medical school. It'll totally go over the.
No matter what age.
Right.
Just get yourself in there. Nice, easy.
That's
5 years.
I hear that's not the only route to deciding whether God, goddess, all that is exists or not. But it's one route.
Oh boy, and how. I well agree with you. Indeed. It's fascinating.
So let me tell you what the original design of the ovary is. Everyone's heard of or most everyone's heard of, that the ovary puts out hormones, and these are powerful biochemicals, and there's basically 4 of them, and they're in families. There's the estrogen family of hormones. In fact, the word estrogen, there is no hormone called estrogen.
Right.
Estrogen is the name of a family. Now, its usage is, there's definitely good reasons to use the word estrogen, but it's referring to a family of hormones. Same with the androgens, testosterone, progesterone. These are biochemical families. And when you study the biochemistry, you see all the family members.
Right.
The mother, the
Cousins
father,
and
the grandparents, the cousins, the uncles, the whole mishpacha is there. Called a biochemical mishpacha. In biochemistry, that's what it's called, I'm pretty sure.
Well, it's written right in those books, that word.
Probably, I think so. If I remember correctly. So what the ovary puts out is estrogens, and there's 3 active estrogens at least. And the most potent one is estradiol.
Yes.
And that's the one that's universally used and known in medicine and treating women. But there's a second major estrogen that's about 80% as potent as estradiol. It's called estrone.
Right.
It's primarily a carrier version of this hormone. I'm not going to define that. And there's a third estrogen that's produced by the female ovary. It's called estriol. It's hormonally active. Now, it's only about 1/8 as potent as estradiol. However, think of this. What's the most prevalent of all the 3 parent estrogens? It's estriol. Estriol is more prevalent. That means there's more of it put out by the ovary than the sum of estrone and estradiol. When you assess a woman, there's about 2 times as much estrone as estradiol. Those are the potent estrogens, we call them. However, there's 1.3 times as much estriol as the sum of estrone and estradiol. So with estriol being the most prevalent of the estrogens, one might think that there's a reason for it.
Chances are.
Chances are. Let's not break out into the song. But chances are.
Chances.
And here's the phenomenal thing. Dr. Jonathan Wright uncovered in the 1970s or 80s. No, I think he uncovered it in 1980s, that there was a medical doctor, a cancer specialist, an oncologist at the University of Nebraska named Henry Lemon. And Dr. Wright uncovered research that Dr. Lemon was doing. He wondered if hormones played into breast cancer. Now, don't get diverted. Hormones do not cause breast cancer. Things cause breast cancer, a lot of things. A lot of things cause a lot of illnesses. But hormones do not cause breast cancer. But Dr. Lemon did 24-hour urine hormone testing in the late 1960s and early 1970s. That's how long 24-hour urine hormone testing has been with us. Dr. Lemon collected the urine of young, healthy women and young women who had breast cancer, or women who had breast cancer. And he found a difference in the hormone profiles.
Ooh,
and what he found in the young, healthy women, that on average, this is an average, averages always are subject to ranges, but on average, the young women had 1.3 times as much estriol as they had the sum of estrone and estradiol. More estriol than the sum of estrone and estradiol. Whereas women who had breast cancer had less estriol than they had the sum of estrone and estradiol. There was a difference in estriol.
Interesting.
And Dr. Lemon proposed that estriol mattered. and he didn't. No one had the full correction or what the cause was or what was going on there. But Dr. Lemon postulated that estradiol mattered. That's his 1970, and he published several papers on this. And Dr. Wright looked at those papers and said, why are we treating with horse urine-derived estrogens? Why don't we copy nature? And he charged his compounding pharmacist to see if there was any pure estradiol out there. He knew there was. And pure estriol out there and pure estrone out there. And Dr. Wright suggested that the compounding pharmacists make biased and triazed. And then eventually switched to biased alone. And what the optimal treatment for women in menopause when they're using estrogens is a combination of estradiol, the most potent estrogen, and estriol. And the most common starting doses include 4 times as much estriol in that bias preparation as there is estradiol. 4 times as much. And 90% of my patients stay on 4 times as much estriol as estradiol. Sometimes we change the adjustment for various reasons. That's technical. I think I even explain it in the book. But that's what Dr. Wright proposed, and oh my, did a lot of us hop on that bandwagon. Now, just how wild, amazing menopause medicine is. Dr. Lemon didn't have an explanation for why the importance of estriol, but in the 1990s, scientists made a discovery that there were receptor sites in the cells of women and men too, of course. And there were 2 different types of estrogen receptor sites. Fasten your seatbelt, folks. I'm going into the weeds.
Okay.
Women's bodies have 2 types of estrogen receptor sites. Not 1, 2, at least. One of them is called estrogen receptor site alpha, and one of them is called estrogen receptor site beta. And now let's look at the common menstrual cycle. Every single month in a young, healthy woman, she's preparing for pregnancy. What she's preparing for is that is excreted into her, is delivered into her uterus and possibly fertilized on its way. Every single month she prepares for fertilization, implantation, and pregnancy. And part of that preparation, oh my God, go figure, includes possible preparation of the breast for breastfeeding. Every single month. And I mentioned this earlier. And the first part of the cycle prepares breast glandular cells for possible breastfeeding. It's during that first part of the cycle, there's actual cell division and addition of additional breast glandular cells, cell division, mitosis, extra breast glandular cells. A woman's breasts get fuller during the menstrual cycle. And if she gets pregnant, those breast glandular cells keep on multiplying, growing, eventually to prepare a woman at the end of 9 months to be able to breastfeed her baby. Breasts get very, very full in pregnancy in preparation for possible breastfeeding. Now, if a woman does not get pregnant in each cycle, oh my God, the whole process is reversed. And at the end of each cycle, if there's not been impregnation, the cells that were new cells that were developed in the breast undergo evaporation, otherwise known as apoptosis. Pretty descriptive word there.
It's a great word, and the definition of it, I know you told me, was not exactly correct.
The cells that were proliferated disappear once a month, and women's breasts get smaller. This happens every single month.
Apoptosis.
Well, the first part of this cycle, there is a point in my reverie here, in my dreaming.
You sure?
I think so.
We love you anyway.
That's why we're doing this together, because you're calling me back to the point. For one thing, we're doing this together. The whole first part of that preparation for possible lactation and all the other things that go on for preparation for implantation, it's under the direction or the stimulation or the inspiration of estrogen.
Right.
And it's being guided by estrogen receptor site alpha.
Okay.
That's get prepared for pregnancy receptor site. And in the breast, that's let's develop some new breast glandular cells and get rolling here. Estrogen receptor site alpha. And if the woman does not get pregnant, the whole disappearance process, the return to the basal state of non-pregnancy, occurs once a month.
Oh no, come back. Dr. R, come back. There you are.
And here we go, folks. That's why I said fasten your seatbelt.
Oh.
Estrogen receptor site alpha is estradiol. Estrogen receptor site beta is estriol. In menopausal women, no breast glandular cell proliferation. We're not super interested in stimulating estrogen receptor site alpha in a menopausal woman. We don't need to prepare her for breastfeeding.
Right.
And we do care a lot about deproliferation. We don't want the breast to undergo any proliferation. So what is the primary stimulant of estrogen receptor site beta, i.e. deproliferation? That means dismantling. That means no proliferation. The primary stimulant is estriol. That's why we suggest that proper treatment of a woman in menopause heavily loads estriol. Ultimately, we just replicate nature. We wind up in a 24-hour urine hormone test. 24-hour urine hormone test. I'm not saying can filter paper. I'm not saying urine 5-point. I'm not saying blood test. I'm not saying cell rate test. I'm saying 24-hour urine hormone test will reveal when a woman with hormones, and here we're focusing on estrogens, whether the proper amount of estriol showing up there and the amount of estradiol is showing up there. And it's all based on being able to evaluate the estrogen metabolites. I'm not going to go there right now. But moral of the story, proper treatment of a woman in menopause includes estriol, and a lot of it. We start out with 4 times as much estriol in our bias as we do estradiol. I'm not trying to compare women who are on Premarin, for example, half the estrogens in Premarin the human female have ever seen. A lot of women did really well getting horse urine-derived estrogens. But in 2021, this very advanced time in human history, or shall we say it's a very primitive time? Let's say it's very primitive because there's too much crap going on around here.
Okay.
We won't go into the crap trap right now, though.
That's a good one. You're a little bit frozen, Dr. R. We can hear you.
How about now, Carolyn?
Nah. Nah.
Oh.
Yeah, I know. Right.
Can you hear me?
I can hear you, yeah.
Well, good. I'll stay with that. You can hear me.
Yeah.
The important thing, as I was saying, is we will not go to the crap trap right now, what's going on Earth.
Okay.
We'll stay out of the crap trap.
It's a word I won't forget.
politics at all.
Yes.
And we'll stick with proper treatment of women in menopause includes the prescription of estriol.
Right.
And the only place you can get this is through compounded biomedical. And getting the estriol estradiol balance proper requires individualizing it for every single woman. So ultimately, we're looking at that 24-hour urine hormone test, and we're making adjustments in the amount of estriol and estradiol. This is what individualization is about. And we love it. Because why? This is 2021. We know a heck of a lot. We don't know everything. But as far as treating women in menopause, my God, we know much basis. When you compare it, when Dr. Wright started going there and Jim Mercer started going there in the early 80s, my God, we know so much more now. It's phenomenal. It's excellent. And what does that allow us to do? Get this better for women. Get it healthier and safer and more elegant and more effective. So individualization of each individual woman, because every single woman is different. There's a wide range in the amount any given individual woman needs of estrogens, testosterone, progesterone, DHEA. There's a wide range in the balance of each individual woman. Requires major individualization, including of estriol and estradiol, the biased. Get it right. Do 24-hour urine hormone tests.
You know, a question did come up, and we've discussed this many times, but I kind of sort of lost it. But the question basically said, do you measure the hormones via blood test or via saliva test? And we talk about this all the time, and we know that you are 100% for the 24-hour urine test.
Yeah, you can get clues from blood testing. And what you want to really know about hormones, there is only one test that I stand behind, celebrate, am so grateful for. I'm here today because of it, the 24-hour urine hormone test. There's other tests that are checking out the urine that are trying to get, but unfortunately, from what I've learned about that particular method, it's just not doing it. So it's collecting urine for 24 hours. There's 3 labs in the United States that do it. And that's how we get to learn, are the hormones that we're treating a woman with showing up in her body in the proper amounts and balance and ratio of hormones and metabolites, 24-hour urine hormone testing. And that will reveal to us how much estrol, just like Dr. Lemon did in 1980. He measured estrogen in the metabolites. And what he saw was the proper amount of estriol in young healthy women and a different amount of estriol, a lot less, in women who had breast cancer. Now, I'm not saying that lack of estriol causes breast cancer. No way. Cancer is a profound illness. It's caused by a zillion things that relate to nutrition and toxicity and too much or too little exercise, or how if we're overusing the biology of the stress response. I'm not talking about stress. Stress is good for us, but the biology of the stress response. And then there's the mystery stuff. When you look at any given woman and or any man who's developed a significant illness, there's mysterious causes too that we just can't put our finger on that relate to. I'm not even going to go there.
Yeah. Let's stay in the happy we're here today kind of place. Because that's a question that will also come up later. So I'll go ahead and move on. We did that one and we did that one. Here's one that is an interesting question. Why can I not tolerate DHEA in any which way, shape, or form? I've been on hormones for 5 years, but DHEA and I do not mix at all, no matter what milligram.
Well, every human's body produces a lot of DHEA. In fact, it's the most prevalent of the steroid hormones. There's more milligrams of DHEA produced by a combination of the ovary and the adrenals than there is anything else. So I would ask some questions at this point. And I would that what dosage of DHEA is being used. DHEA overdose is very common. Now hear this. My mentor in DHEA said no woman should be on a dose of DHEA oral greater than 15 milligrams. I'm sure there's extremely rare exceptions to that, but look out. You go to your local drugstore, and over the counter, you can pick up a 25 milligram DHEA, 50 milligram DHEA. It's an accident, a trouble waiting to happen. This never should be allowed because women should not be on over 15 milligrams of DHEA orally every day if they're taking it, or again, by mouth. So I don't know, there's as often as the case, in order to really answer the question of the specific questioner, there would be a lot more information I need to know. But I think that there's a detectable issue here. And the first thing I would ask about overdose, and extremely rare, I don't want to say this, but there are some benign tumors, primarily of the adrenal gland, in which there's too much DHEA produced. And there are some genetic variations amongst the human race. For example, there's Italians can have an increased basic production of DHEA. And they're probably not the only ones. It just happened to be an Italian man that we found just by accident a very, very high level of DHEA. And I was concerned about adrenal tumor. And we walked down the whole CT scan, MRIs, no adrenal tumor, only to learn eventually that there is a genetic variant where there's excessive DHEA. So you wouldn't want to give someone who's putting out this robust amount of DHEA, it's part of their genetics, it's some additional DHEA. As with almost everything in medicine, if you hunt and peck, dive in, put under the metaphorical microscope what's going on in any given individual, so often, and not always, so often that what's going not correct and not optimal can be uncovered and dealt with. So often. So we have a ritual for doing that in the menopause method. We call it turning on the screws. No, I just made that up.
Haven't read that one yet.
Just made that up. We just hunker down and we ask the questions and we do the testing and we follow the bouncing ball, and you figure out what the heck's going on in that situation. And we train and mentor our doctors to do that. And it keeps it infinitely interesting because this is one of many or thousands of challenges that can arise in treating women in menopause with hormones. Something's going on. You get trouble with DHEA. Could be as simple as you're taking too much, or there could be other reasons. Even something like a benign adrenal tumor that's producing too much DHEA and thus a few other hormones usually. And, rarely it's adrenal cancer.
Yeah.
In the course of my 50 years of being a doctor and 25 years of specializing with women in menopause, bioidenticals, hormones, by golly, by gum, I picked up on 24-hour urine hormone testing in one woman these very, very high levels of hormones, adrenal hormones, cortisol, DHEA. And sure enough, we did an MRI, or I think it was a CAT scan, an MRI, I forget. And it revealed a small tumor in the adrenal, and she had that adrenal gland removed. And the anesthesiologist commented to this patient that he had never in all his career seen adrenal tumor picked up so early. Why? Because that 24-hour urine hormone test picked up the numbers prior to the trouble.
Wow.
And it was a benign adrenal tumor, but you start putting out excessive levels of potent hormones, ain't nothing benign about that. But
No.
it's not a cancer, but it is a recipe for trouble, that is for sure. So yeah, follow the bouncing ball right down to the level of CAT scan. Here's something else that happened. I saw on a 24-hour urine hormone test in a woman that I was treating for menopause. When we eventually tested her, is because we don't test right out of the gate, we wait the 3 to 5 months to test her. I saw these high adrenal cortisol levels. And we were setting her up for a CAT scan, the whole ritual. And then as an afterthought, I said, I want to see every single hormone, every single supplement that you're taking.
Oh.
Roll them out, stick them on that desk. Let's read the labels. Now I do this via telemedicine, so but she did it. And I said, and I want a copy of every one of those labels you're on. And one of the things that she was on was a supplement, a quote, adrenal support supplement. It had a bunch of proprietary ingredients in there. Well, the law says you can't put cortisol in that. But what's been known throughout the supplement industry is there are some companies that don't have 1,000,000% integrity, and they want their supplements to have the effect. So they're throwing hormones in there, and they're not listing them on the label. Now, that is not common practice. When you're dealing with professional companies, as I have, for 50 years, these people, the ones that we deal with, they have a tremendously high level of integrity. This is run by and owned by scientists or originated. They care about this stuff. They're not going to throw some crap in there. Oh, here
yeah,
we are.
right.
Dealing with crap again.
Yeah, right.
But there are some supplement companies that are doing that. They're out there.
Oy, consumer beware.
That's right. And when you're throwing hormones into a supplement and not mentioning it, you're going to get a major effect. And one thing about cortisol is it gets people high, which is why a lot of people have been put on prednisone and other forms of cortisol. It's hard to get them off because they get addicted to the high. That's not the only reason it's hard to get them off, but they get high. A lot of people do. Not everybody, but a lot of people do. So that's some of the motivation to put cortisol in, quote, adrenal support formulas. Well, what do? We asked her to stop all of her supplements, especially the ones that had adrenal support in there. And sure enough, we tested her 2 months later, totally normal adrenal corticosteroids. So I'm not saying this is what's going on with you, but there's a lot of stuff that can go on, and there's a lot of moving parts to consider. What does it do? It takes you down to your main job as a woman in perimenopause and menopause is to go shopping. Ask all your friends. Go shopping. Find a healthcare provider that's licensed to prescribe hormones. It's a physician, nurse practitioner, PA, in some cases, a clinical compounding pharmacy. Find an expert. Find someone that really cares about this, that's gone through training programs and mentoring programs, knows what they're doing. They know how to sort this stuff out. That's your job. I love it, the amount of interest there is in this field.
Oh my God, it's a big shoot, you know?
It takes you down with all the information that I share here. Ultimately, treating women in menopause requires the ability to write a prescription for hormones. And there's a reason why you have to write a prescription for hormones. These things are so strong, you can make so many errors with them. They're the strongest biochemicals in our body. And they're capable of doing a tremendous number of things, including fight or flight. So they're strong. So I think it's wise that these are prescription items and not over-the-counter items. With one exception, progesterone, you can do over-the-counter progesterone safely with the strengths that are being put out there. But the rest of them are prescription items, and they need to be, because you want whoever is writing a prescription to know what they're doing, big time.
Yeah.
I just saw internet connection, and you know what? I have Ethernet connection, and you know what? I had to unhitch it last night, and I didn't put my Ethernet back on. Eek! Thank you. Martha,
Thank
thank
you very much, Martha. Thank
Detective.
you.
Detective has uncovered the culprit called I forgot to put my Ethernet back on as I had to go non-Ethernet for a while yesterday. Oy, gewalt.
Like Vault, don't even talk to me about that stuff. I can't even wrap my head around Ethernet. I don't. Daryl, thank you, Daryl. He hooks it all up. Thank you, thank you, thank you. But you're not frozen, so whatever you did worked. And thank you, Martha. So we have a few minutes left. Let me ask you this. In my biased, I am on biased 80/20. We've talked about this many times. It still continues to confuse. Will this help with diminished desire, brain fog, and reduced stamina?
Well, yes. Oh, it's another yes answer.
We got lots of yes answers today.
Well, let me change it from yes to, if you're a woman who had what you desire that you were satisfied with and really clear cognition, mental abilities, and what was the third one?
Brain fog, reduced stamina and desire.
And stamina, and you had what you considered to be normal, and then you go on into the perimenopause or menopause years, and you get reduced cognition, reduced libido, reduced desire, reduced stamina. You can bet your bottom peso that this is due to the loss of ovarian hormones. Pull out them pesos and get betting, because, or another way to do it is spend those pesos on the menopause method or some other expert approach to treating women in menopause with bioidentical hormones. Because I can't tell you how many women have the very symptoms that you've named, plus other symptoms. And one of the most rewarding things is to hear from a woman, oh my God, my brain fog totally cleared. Some brain fog needs more hormone treatment and more expert hormone treatment than others, but the majority of women who go in and have cognitive challenge that they never had in their life, now they do, it's totally alleviated by reasonable replenishment dosages. Rarely there's someone who needs more than the usual doses. They need very robust doses. But whatever it is, if you're a woman with cognitive decline, you want to get those hormones right. Oh my God. Because it's not only cognition that's declining, so are your bones declining. So are your muscles declining. So are your arteries declining, your skin, your vagina, your bladder. You've heard this before. But yeah, brain fog, that you never had before in your life. There are other possible causes of compromised brain function. But in a menopausal woman, I don't know what percentage is, but it's got to be up around 99% of the women who are getting brain fog in the perimenopausal or menopausal age demographic. It's from low hormones, primarily low estrogen. So that's the great news. Get the estrogen up to where you should be with it. You could define should be, but you want your healthcare provider to know what should be is, and we know what should be is, because we've extrapolated from the medical literature. I did it personally. Medical literature, science studies tell us what's too little estrogen. It also tells us what's too much. But when I see a 24-hour urine with too little estrogen, I go, nope, not acceptable. You're not going to like that for the long haul.
Right.
So, yeah, go for those hormones for your whole life. I am. Just to give you a clue, I take this hormone every single day. It's called testosterone. And I take a few other things too, because it's not the only thing that is important for men to take. I have that bottle with me for my whole life. Every day I'm blessed to be on this earth, I will be taking my testosterone. and my other stuff.
I'm right with you on that for sure. 100%, you know.
And oh my God, the clock
No,
struck.
don't even say it. Don't even say it. It can't be so. Thank you. I saw what you were saying there. So, we got to almost all of our questions, which is really pretty remarkable. And we will certainly get to more. It is the 4th of July weekend. I want to wish you an amazing, amazing weekend. All of the ladies that came up today, thank you so much. Very safe, happy. Thank you. Thank you. Enjoy. And we will be back on Tuesday. I get these questions. We will get to them. I will help to answer them too, to the best of my ability without any medical advice from me. And I guess that's our closing out from Carolyn Shapiro and the cats and Dr. Rosensweet and the menopause method.
Hasta la vista.
Yeah, you're talking about pesos, so hasta la vista is really appropriate. Right? It's not
Yes.
drop.
Por seguro.
Oy vey. That's what I think.
So good to see you, Carolyn. Thanks, everybody. Thank you, Carolyn.
No, thank you.
Or
Really.
should I say Carolyn Shapiro?
Always my pleasure. It really is, So,
All
for
righty.
everybody, have a great one and enjoy. And we will talk to you on Tuesday.